pencil, I make my test, and I make my notes. See how this goes? Red means it's important. So, as I'm talking about things, I'm hitting these points. So I want to make sure that you guys are listening to what I'm saying, okay? And writing down what I'm saying. All right, so assessment. Things we're going to assess it starts on page 724, I believe, the physical assessment page. There's also a video on here, and I hope that can get to work. But when we're doing a neuro assessment, we're going to think way back to fundamentals. All this stuff should be reviewed, fundamentals and A&P type stuff. So the first thing we're going to assess is their level of consciousness, their LOC. The best indicator of neurological deterioration is a change in level of consciousness. So that's usually what we see first, is a decline or a change. Maybe they were alert and oriented when you got here this morning. I can always tell you to do your assessments pretty early in the mornings. Because then by the end of the day, we're different from the baseline we were this morning. They were alert, awake, oriented, everything was fine. Then they tend to deteriorate throughout the day. So we tell you to go ahead and get your assessment early. Assessing LOC involves responsiveness and orientation to person, place, and time. There's different categories of conscious. There's lethargic. That's just you're kind of groggy, they're tired. You can wake them up. When it's time to give them their medicines, then they're going to go right back to sleep. They really don't want to eat. You've had those patients where they're like, should we wake them up and give them their meds? Yes. We're going to wake them up. They'll go back to sleep. Those are just your lethargic patients. Stuporous, they're almost unresponsive, but they're going to respond to pain. So how many of you have had external rub somebody? Y'all reach up and kind of take your knuckles and rub on your sternum. Hurts. Even if you just do just a little bit of pressure, it hurts. So these patients are almost comatose, but if you give them a good sternal rub, and they're going to come to. They're going to respond to some sort of pain, whether it's a grimace or a movement or a moan. They're going to respond to some sort of the pain that you inflict on them. And then you've got comatose on page 725, and those patients are unresponsive. Page 725, table 35.8, talks about the different levels of consciousness. You guys remember the Glasgow Coma Scale is part of your assessment that you do in EHR, GCS. You guys have seen on Grey's Anatomy or Chicago Med when they roll in and like flying in the ER, they're GCS 8, they come flying in. That's what they're doing. They're assessing their level of consciousness in the field, and they give you that number. The highest number you can have is 15. That means they're awake, alert, oriented, moves all extremities, responds well, answers questions appropriately. Everything's fine with that patient. Neurological wise, the lowest score is going to be a 3. Okay, so these patients are unresponsive, not moving, no stimuli, no pain, no response to anything. So a score of 8 or below indicates that we've got some neuro issues going on.
You said 8?
8 or below. And page 725, table 35.9 has information about that. Just to remind you. But you guys have seen that in your charting, in your EHR tutor, the charting that you do. MMSE is mini mental status exam. This is an assessment of the patient's orientation, attention, calculation ability, memory, and language ability. Patients are asked these questions and then they're scored accordingly. Page 726, table 3510 talks about how to score them. So these are questions that we're asking them: who are you? What is today? Where are you? Count backwards by 7. We'll tell them, I'm going to tell you 3 words.
A memory
and I want
question.
you to
It's
memorize those words.
like you'll go
And then we'll continue
person,
with our conversation and ask more
woman,
questions.
man,
And so just
camera,
those 3 words I told you to
TV.
earlier. What are those 3 words?
So they say, could you
And see if
repeat
they
that?
can recall those words.
So I said, yeah.
And it's something
So
simple
person,
like dog,
woman,
dollar.
man, camera, TV. Okay, that's very good.
And then you carry on a conversation
If
with
you
them.
get it in
go
order,
on,
you get
listen to
extra
their heart and
points. If
lungs
you-
and all that, and then you say, Mr. Smith, remember those words? Being able to see if they can recall the information that you gave them. So that's all part of some examples of the questions that you ask them on a mini mental status exam, which I'll pull up in when I get done with this chapter of your cranial nerves. This is AMP stuff, okay? So we're talking about, there's easy ways to remember it. Some people remember them in order. And there's a picture I'll show you in a minute that has like the face and which numbers go with which part of the face and those sorts of things. But it's going to be important to know which cranial nerve affects which area, simply because if we know that there's a problem with a certain cranial nerve, what are we going to see in our patients? Is it going to cause difficulty swallowing? Is it going to cause a problem with their peripheral vision? If we've got, say, cranial number 3 is oculomotor, and they're supposed to be able to look up and down without moving their head, okay? So if we have a problem with cranial nerve 3, they're not going to be able to do that. Does that make sense? Like, you got to be able to know what cranial nerve is responsible for what, so then we can answer questions about that and how the patient is going to present. Okay, so we're thinking way back to AMP. I know for some of you it was a long time ago, but we got to go back and build off that base. So cranial nerves are going to be very important to remember, and I've got some little hints on how to remember those, how to refresh yourself about it. Okay. Motor assessment. So this is where we're testing, inspect, and assess the muscle mass and tone, as well as strength and quality between the left and right side. This is where we ask them, can you squeeze my hand? Can you push your feet? Can you pull back? Those sorts of things. That's we're testing their motor assessment. We want to give them clear, definitive commands when we're telling them to do something. You know, squeeze my hand as hard as you can with that left hand. And a lot of people won't use their full strength, they're afraid they'll hurt you. So you have to tell them, you're not going to hurt me, just squeeze my hand as hard as you can. Or I need you to move your right foot up and down. Or I need you to hold up 3 fingers on your left hand. You have to be very definitive whenever you tell them to do something, so that we know that they're understanding the direction. Sensory assessment. We want to determine if the patient can feel or identify specific sensations, such as temperature, vibration, superficial or deep pain. You'll see, you typically won't do this, but you'll see maybe the neurologist coming in and doing things like taking the end of a pin and poking the bottom of their foot, or you know, to see if they feel that stimulus, to see if they can feel the difference in something that's hot and something that's cold. They'll take the tuning fork, you know, that vibrates, and hit it and see if they can feel it vibrating on them. So that's how they test their sensations in their extremities. The dermatome chart is on page 721, and it helps you to know if there is a injury at C3, okay? What is going to be paralyzed or affected everything below C3, okay? So that's going to be their breathing, that's going to be their bowel and bladder control, that's going to be all their extremities. So we're looking at quadriplegia, all 4 extremities. So that dermatome chart helps you to look at the different levels of injury when we start talking about spinal cord injury. We've got to know what level. If we're at, we have a fracture that spinal cord severed at L4. Okay, that's your lumbar 4. That's your lower back. Are we going to have trouble breathing? No. Cool. Because that's up here. And L4 is down here. Okay? So we're going to be paraplegic. We'll have problems from our waist down, but we should be able to sit, maintain trunk control, breathe on our own, move our arms. So we need to be able to know those levels. That dermatome chart is very important when we start talking about spinal cord injury, or maybe there's a tumor on the spine and it's compressing a certain area of the body. what are we gonna see in our patients? We're gonna see deficits below that level of injury, okay? Everybody follow me with that? All right, cerebellar assessment. This is where, remember the Romberg test back in the day, the Romberg test? That's whenever you have your patient stand up and they close their eyes and you stand close to them and like fall, but they're supposed to put their feet together, close their eyes, and you're looking for them to stand completely still and not sway to one side or the next, okay? So you're supposed to be able to maintain their balance and stand completely straight. It's called the Romberg test. It helps us to gauge whether or not their cerebellum is intact and with no problems. So this is what we're going to watch on walk. We watch their gait, see if they've got any swaying or shuffling of the feet, how they sit, their posture. These are all things that we're assessing just by looking at them. I actually see a neurologist. I saw her last Thursday. That's why I was out. And so she does all these exams. It's not something that you typically do in your normal healthy visit, but if you actually have neurological problems, you see a neurologist and all these exams are done every time you go to see them. So she does test all the cranial nerves. And can you look up? Can you look down? Can you stick your tongue out? Can you move it side to side? Can you turn your head this way and this way? I need you to get up and walk across the room for me. I need you to sit up how you normally would at your office and use your desk. I need you to push, pull, squeeze, all the things. So she does all that every time I'm in there because I actually have neurological issues. So it's not something that if you are working at a clinic that these are going to be assessments that you do every time. Or if you're working in the hospital in a regular med-surg unit, unless they're exhibiting neurological problems, these exams are not something that you do on the daily, okay? They're important to know for people that specialize in this. If you go to work ICU, if you go to work on a stroke unit, if you go to work, we do progressive care, that's a stroke unit. So we're really big on their level of consciousness, the Glasgow-Coma scale, their sensory assessment, their cerebellar assessment, their balance, all those sorts of things, because it's a floor that specializes in neuro. Reflexes, involuntary and automatic responses to stimuli that provide the body with protection and help adjust to the ever-changing and sometimes dangerous environment. The reflex occurs when a sensory neuron carries a stimulus to the motor neurons in the spinal cord. The motor neurons carry the stimulus from the spinal cord to the muscle. And all this happens so quick. Say that you touch a hot eye on a stove, okay? Think about how quick that happens, how fast you jerk your arm back, okay? Those neurons are being sent from the hand that senses it's hot, okay? Gets to the spinal cord, goes to the brain. Brain tells the muscle, move, right? Move that hand out of the way. Happens in a split second. I think that's so amazing. It's so amazing to me that it just happens so quick. But that's a reflex, right? Your reflexes, and this is crazy, but a lot of times you get hit. It's a reflex to hit back, isn't it? Just immediately. Moms have reflexes when we're riding in the front seat, and we step on the brakes, it's like, bam, you gotta put your arm over there, you know? And it could be like, my dad's riding over there, and I'm about to just hit him in the chest. It's a reflex, you know, because I'm used to my kids riding over there, and that's a mom reflex. And we joke about that, but it is. We do it subconsciously without our brain even thinking about it. It just happens so quick, so I think that's it. All right, let's see. Babinski's reflex, think back to your babies. It's noted to either be positive or negative. We're usually going to we'll take like a pen or something. We'll take a pen and we're going to stroke the outside of the sole of the foot. So we're going to pretend this is a foot, okay? And we're going to stroke the outside in an upward stroke. And if the patient's toes flare out, it's positive. And it's negative if the toes curl downward. How many of you have like, I'm super ticklish on my feet? So if anybody touches my feet like this, my toes curl down. That's normal. Like you tighten up, you know, and your legs stiffen up. But anytime somebody does this, tighten like this, it's normal in an adult. In a child less than 1 year old, you're going to see them flare out, and that's fine. But would it be appropriate for an adult to flare out like that? No. Okay. So those are some reflexes that we check. Some things that could cause a positive reflex, like their toes flaring out in an adult, would be multiple sclerosis, traumatic brain injury, or alcohol and substance abuse, if they're under the influence. So less than 1 year old, it's normal for that to happen in children. But if they're older than that, we can start suspecting something neurological going on if they have this type of positive reflex.
Can you repeat those three that you just said?
Multiple sclerosis, traumatic brain injury, and alcohol or substance abuse.
Thank you.
Vital signs and ICP. So think back to your vital signs, and then what is ICP? Intracranial pressure. Okay? So your vital signs going to be your heart rate, blood pressure, and respirations are all regulated in the brain and the brainstem. Changes in the vital signs are usually late signs of an increased ICP. So if we can have several different reasons to have an increased ICP. Normal ICP is 7 to 15. So I'll tell you a little story. Told you I was a neuro patient. In 2020, I was having terrible headaches. Couldn't really figure out what was going on. I thought it was COVID. That's the first sign a lot of people have a headache. Kept testing positive, being negative, everything's fine. That fall, I started having some blurred vision in my right eye, and my headaches just wouldn't go away. They were really worse when I was laying down, and I felt like my head was about to explode. And when I would tell people that, my head is going to hurt, so my eyeballs going to pop out of its socket. And so anyway, I ended up being taken to the ER, DCH. We don't have neuro around here. They do have neuro in Tuscaloosa. And so I went, and I was immediately admitted to neuro ICU. And so they did a lumbar puncture. That's how you can test the ICP. So they went in and did a lumbar puncture on my lower spine, and they found out that my ICP was in the 40s. And so normal is 7 to 15, okay? So now we're like, why in the 40s? Why is my ICP up? Why is the pressure up? So we start rolling out all these different things. Is it a brain tumor? Okay, no, it's not a brain tumor. All that stuff came back. So then, to lower the ICP, what they'll do is they drain CSF off of your spine, which ultimately is off of your brain, okay, the cerebral spinal fluid. So come to find out, I ended up with intracranial hypertension is what it is. So my body makes too much cerebral spinal fluid. So there's too much on my head and my brain, and so the pressure rises. So you have all the signs and symptoms of a brain tumor, but there's no tumor. So it's also called pseudotumor cerebri, if you've ever heard of that. Because pseudo, meaning false, it gives you all the signs of a tumor, but there is no tumor, so it's a false tumor. So you have all the signs, the blurred vision. The reason why is because there's so much pressure. It starts to put pressure on the optic nerves. And you can actually go blind. And so, permanently blind. So, the optic nerve can be depressed by all the pressure that's up there. And that's what causes the blindness. So I have to be real careful. I see an ophthalmologist over there every 3 months. And checks my eyes and does all these other exams to make sure that I don't have any recurring problems from it. But the solution for a lot of people, first step is medication, which luckily, after 2.5 years, I'm able to come off of some of those meds because the meds make you feel terrible. So I'm on a medication called acetazolamide, and what that does is it helps decrease the amount of CSF that my body makes. So I've had a couple of lumbar punctures to drain the fluid off when it gets really high, but for the most part, it's been managed by meds pretty well. But some people will even have to have what's called a shunt, and they'll put a shunt in the brain and run it into the peritoneal cavity in the belly and drain the excess cerebral spinal fluid off the brain into the belly. So that's another way that you'll see in your neuro ICUs a lot of times that they will release the pressure by implanting a shunt. Sometimes they'll drill burr holes in an emergency situation to release the pressure. They'll actually drill holes in the brain to release the pressure off the brain, and allow the brain to swell, especially if you're in like motor vehicle accidents or a traumatic experience like that. So neuro is very interesting to me. I guess I relate to it so well. Classic signs of ICP, increased ventricular pressure, is what we call Cushing's triad. And the symptoms that go along with Cushing's triad are three different things. I'm sorry, I'm still on this one. Three different things we look at. We've got increased blood pressure with a widening pulse pressure. So not just increased blood pressure, but we've got, what's our pulse pressure? The difference in the systolic and the diastolic. They way back to fundamentals now. Okay, so we're thinking, let's just throw out there, we've got a blood pressure of 172 over 72. What's the difference in those two blood pressures? 100, right? So our pulse pressure is a large number. That's a big number, okay? So we've got a high blood pressure with a widening pulse pressure. We've got bradycardia, so our heart rate's 50. And we have irregular respirations. So that meets the criteria of all three things to give us what's called Cushing's triad. That tells us a lot of times that our ICP is up. It's a late indicator, but it will tell us that our ICP is up. So if you're given a situation with those sorts of vitals, start thinking about we might have an increased ICP. Then we got to start thinking what could cause that increased ICP. Okay? Diagnostics. A lot of these you guys are going to already know because they're done all the time. They're just done on the brain in this case. X-ray. X-rays are good for assessing the skull and spinal column for fractures, compression, stenosis, and malformation. Now your fractures could be from like compression fracture, falling off of the roof or falling off a ladder, okay? Hit down on your butt on the ground. Think about that spinal column compressing like that. Doesn't have to be a fracture that's broken like a clear line through a bone, right? We could squish those bones and vertebrae together and still be a fracture, a compression fracture. So we see a lot of those with the spinal column, the compression fracture, especially from falls. So X-rays are good indicators for that. You're going to notice when you get out in the real world that a lot of the tests that we run depend on insurance. And it sucks. I'll be honest with you, because a lot of people need to skip straight to the MRI. We don't need to be wasting time with an X-ray. We don't need to have a CT. We need to go straight to an MRI. But for insurance to pay for it, we got to do an X-ray, then that comes back inconclusive. Then we do a CT, that comes back inconclusive. And then 3 months later, we've got a $3,000 MRI that actually shows us what we should have seen 3 months ago, right? But because insurance don't want to pay for those fancy exams until you've done all the other steps, you'll see your physicians order the least invasive and cheapest test first. Irritates me to death that money is how the doctors have to operate now, but it is a reality. So you'll see a lot of people, and you're like, oh, they just need to send him for an MRI, especially your stroke patients. They come in, what's the first thing they get? CT. We know that sometimes the strokes aren't going to show up on CT. It may take days for them to show up on CT. We need to have an MRI done, but we got to do CT first. So, X-ray is going to be your first line of things that we do for these patients. CT is a cross-sectional image. If y'all are in clinical and you ever have the opportunity to go through and actually look at pictures, they're really interesting to look at. The CT is kind of like slices. Pictures is X-rays, but it's in slices. You can scroll through and kind of get the whole picture based on each little slice. They're usually done as routine for a suspected stroke. What are some things that we educate about and that we talk about to our patients before we have a CT. CT is something you gotta have an informed consent for. What should we talk to them about? If we're gonna have contrast, iodine allergy, shellfish allergy, talk to them about, are you gonna be able to lay still? You know, do we need to be able to give you medication prior to pre-medicate? We need a patent IV. Your radiologists are gonna want 20 gauges above the wrist. They don't like hand IVs. They don't hold, the iodine and the contrast dye is injected so quickly that those little hand veins just don't hold up. So, yes.
You said the IV needs to be good.
At least a 20 gauge above the wrist. So we need a patent IV. We want to check their allergies. Another thing we need to check is their kidney function. We give them this contrast dye. Are they a chronic renal failure patient who's not going to be able to get rid of this dye in their body? You know, we want to check their kidney function. A CT is really optimal for visualizing bony structures. It's the best picture. Yes, you can see bony structures with an X-ray, but a CT is going to give you better bony structures. And you can also see soft tissue as well. But your MRI is going to give you the best soft tissue exam. All right, PET scan. Positron emission tomography, PET scan. That's a picture of a PET scan right there with a brain tumor. That's what we call a hot spot right there. So where it lights up, you hot too, aren't you, Mel? Burning up. So what happens is the radioactive material is injected and it tends to run to or attract any increased metabolic activity in the body. So these cells are like they're reproducing super, super fast. And so that radioactive dye is gonna be attracted to that. And it lights up on our screen that that's a spot, it's a hot spot. And that's where we've got highly metabolic activity going on. That's suspected cancer right there. So you're gonna see your cancer patients are gonna have PET scans. Say we have breast cancer. They're gonna do a PET scan, most likely the whole body eventually. And you may have light up in the liver, the lung, the bone. That tells us metastasis, okay? It's gone from the breast, it originated there. Now we've got metastasis to those other areas. So we use this to be able to determine where we have those hot spots. We don't want the patient to drink any caffeine or alcohol prior to their exam or tobacco for 24 hours prior to that exam. And they gotta be able to lay really still. MRI, magnetic resonance imaging. Those are your really good 3D images. We assess the brain for injury, spinal column, look for tumors. We can see if there's any bleeds in the brain. What are some things that we ask our patients prior to getting MRI? Yep, any metal. Got a pacemaker, got any implanted devices. So I was at the hospital on Saturday, and I have my bed sits on Saturday, and so anyway, I said, where is the girl's name? Autumn. So where's Autumn? Anybody see Autumn? Oh, she's taking out nipple rings in 402. Oh, like it was just so random. Like I just wasn't expecting that, you know. And they're like, oh yeah, they're going out for MRI, and they discovered that she had nipple rings, and those definitely have to come out, right? And so poor little Autumn was down there removing the nipple rings. Any implanted devices, pacemaker, any bone like plates, screws, anything like that in their body. Have you ever been shot? A lot of people don't think about stuff like that, especially been shot like a bird shot. Have all the pellets in your body that weren't ever removed. So we ask those good questions. Yes, ma'am.
Yeah, I worked in ortho.
Yeah,
so,
you tell us.
Talking to radiology, they use a different type of metal in those implants, so they usually don't interact with the MRI.
Okay.
Unlike the pacemaker,
they have to call a number and they put something over it. They actually put a magnet on top of it and turn it off for the time being. So you can have those, but we gotta know about them.
Same thing with like braces.
Probably, I don't know if they do for braces.
There might be a different type of metal that.
Maybe a different
Surely you would.
There's a checklist usually that you go through before you send them to radiology, and you'll make sure like any piercings, any implants, anyone you just kind of check. So your job is to let the radiology tech know, or the radiologist know what they have, and they can take it from there. Yes, we do have an implant, whatever, we have a pacemaker, then they can call the people and get it all turned off and get it all taken care of. Our job is to let them educate about what we're doing and ask those questions. All right, cerebral, cerebral angiography. It's a radioactive dye that's inserted through an artery. It's usually done in the femoral artery. And it's continuous imaging while the dye circulates through the body. It's used to evaluate cerebral and ocular vessel occlusion. So you're going to be looking to see if we have any. It's used a lot of times for your stroke patients that have had an embolic stroke, like a clot that's in the brain. Carotid diseases. Who was with me the day that we had carotid? They were going in. They had saw patients like 90% occluded in the carotids. They were going in and coming out stents. Did you go down for that? Also helps us with aneurysms and any other vascular disorders. So I had this done too. They wanted to make sure that the vessels in the back of my brain were actually open and allowing the fluid to drain out like it's supposed to. So once they were able to determine there was no occlusion, no clot, nothing like that in the back of the brain, then they can say, okay, well, it's not a drainage problem. So now we've just got a volume problem. We got too much CSF.
So, what was the reason for that coming out?
Me? I just made too much. Like my body couldn't keep up with the amount of cerebral spinal fluid that was being produced. So I'm on meds to decrease the production. But anyway, for some people, it could be a drainage problem. Like maybe there's an occlusion or a narrowing of the vessel in the back of the brain, and that's why it's not draining out. So they would get a test like this to make sure that all our vessels are open and everything's draining like it's supposed to, everything's flowing like it's supposed to. And if anything needs to be stented or opened up, then they can do that. Okay. A lot of times with the cerebral angiography, it takes about 60 to 120 minutes. You gotta lay completely still. With a lot of these tests that are, we inject the dye, they tend to get this like really warm, flushed feeling. If you've ever been with somebody or had a CT or MRI or any type of something where they put in dye, you get this really warm feeling. Feels very fun. But just kind of give them that information. You know, you may feel warm and flushed. CT angiography, dye is injected into a vein, not an artery. And it's used to evaluate the cerebral vasculature. So same concept, except this one is done through an artery, or a vein and not an artery. LP, lumbar puncture, most common procedure done to get a sample of CSF and to measure the pressure. Increased pressure may mean obstruction, like we just talked about, or it can mean overproduction, which is what I have. Glucose or protein, as well as a cloudy color that's in the CSF. CSF is supposed to be clear, crystal clear. And if it has any color to it whatsoever, or has any cloudiness to it, then it alerts us to the fact that it potentially could be infected. So I have an infection going on. If it's bloody, it could mean that there's bleeding into the subarachnoid space, or it has been a very traumatic spinal puncture or spinal tap. So mine have all been under x-ray. Sometimes you'll see they'll do lumbar punctures at the bedside. I wouldn't want that, I opted not for that. I would rather go to interventional radiology and it be done under x-ray so that we know exactly where we're going into the spine. Sometimes in immediate situations, they'll do them at the bedside and you put the patient either on their side, they're lying flat on their stomach, or they're bent over something, kind of like getting an epidural. And so they'll numb up the area and then they'll go in, but they're sticking blind. You know, all they're doing is filling the spine and sticking. I didn't want that. And I actually told them, I was like, I got some meat on my spine, I'm afraid you're not gonna feel the right thing. So I would really prefer to be under x-ray. And they understood, they just did what I asked them to do. But so that way you can do an interventional radiology where they actually go in and they know they're watching where they're actually sticking.
How bad is it?
It hurts. It hurts. So the numbing's not bad, it's lots of pressure. You feel like lots of pressure. You're sore for a couple of days afterwards. You definitely feel like something's in your spine. But I mean, it's not unbearable. You know, I wasn't screaming or anything. But you gotta think about doing this on children too. Like they come in with maybe suspected meningitis and we've gotta do a lumbar puncture. You have to knock those kids out pretty much because they're not gonna be able to be still. If you're putting something in their spine, they're gonna be super still and be able to follow directions. So you can't stick somebody's spine when they're floating around. So probably have to sedate them. Let's see. So the spinal needle is actually inserted into the space between L3 and L4. You do have to have an informed consent for this. They're going to be laying on bed rest for 4 to 6 hours afterwards. Complete flat bed rest. That was the worst part. And I did end up getting a spinal headache where there was a spinal leak. Cerebral spinal fluid leaked out. And what they can do is they draw blood from you and they do what's called a blood patch. And they will inject the blood into where they drew the CSF out, and it clots and causes it to close up. So it causes a real bad headache. They call it a spinal headache. A lot of your C-section mamas that have had epidurals or spinals will end up with those spinal headaches if they don't lay flat like they're supposed to. Anytime we're sticking anything back there, we make sure that they're not going to any antiplatelets or any anticoagulants. They'll be at risk for bleeding. So brain function, I put this up there just because I want you to know, just think back to A&P. These different lobes, say for instance, we're having trouble with concentration. Patient comes in, they're not able to concentrate, they're making completely irrational decisions like giving all their money away, poor judgment, and personality changes. They're having all these different issues going on. They're like, this is not like my mom. She's never been this way, and now she's broke and she's giving all her money to this person she met online, and she's just making poor judgment skills, or she can't concentrate, and so we can start to think that, hey, maybe there's something going on in the frontal lobe. Knowing which lobe is responsible for what helps us see that if we're having these sorts of problems, then maybe it's related to the frontal lobe or the occipital lobe if we're having visual problems, or if we're having trouble with memory, maybe it's in the temporal lobe. So just kind of refresh yourself about those lobes and what is housed within each lobe. And then there's the cranial nerves is one way to remember that. to touch and feel, very giant volcano. I uploaded it under that module. Cranial nerves by the numbers. And it shows you the phase. And this one is an old Olympus towering tops of Finn and German viewed some hops. Is that the one y'all heard before? An old Olympus towering tops of Finn and German viewed some hops.
Yeah.
Close.
Whatever works for you.
I thought,
It's like 2 pages, and it tells you olfactory nerve located in the nose, controls the sense of smell. To assess it, do X, Y, and Z. You know, like it just tells you real brief. So this is a good article. You can watch that little assessment video. What it is it's a nursing instructor in her sim lab, and she's doing a head to toe assessment on a mock patient. And so it just kind of goes through how you would do an assessment.